Good evening, everyone. Thank you for joining our webinar. We're looking at opportunities to improve the care of our patients with inflammatory bowel disease, in particular with ulcerative colitis, with a focus on new and emerging therapies. I'm Dr. Aline Charabaty. I'm the Assistant Clinical Director of the GI Division at Johns Hopkins School of Medicine, and I'm the Clinical Director of the IBD Center at Hopkins Sibley Memorial Hospital. I'm joined by two very special guests and good friends. Dr. Dana Lukin, he's an Associate Professor of Clinical Medicine and the Clinical Director of Translational Research at the Jill Roberts Center for Inflammatory Bowel Disease and the Advanced Fellowship Program Director at the New York Presbyterian Hospital, Weill Cornell Medicine. Welcome, Dana. Thank you for coming. You've always been a great supporter of Monday Night IBD, so I'm really excited that you join us tonight.
It's really an honor and a privilege to join you and Marla. I'm really looking forward to the conversation. So thanks for having me.
Absolutely. And I'm also super excited to have Dr. Marla Dubinsky. She's been very reluctant to step her feet or hands on Twitter. So I'm very excited to convince her in the back door, like through a webinar before she starts tweeting. But Dr. Dubinsky is a professor of pediatrics and medicine. She's the chief of pediatric GI and nutrition and co-director of the Susan and Leonard Feinstein IBD Center at Mount Sinai Hospital, Kravis Children's Hospital, and the Icahn School of Medicine. Marla, welcome, and thank you for being with us tonight.
Thank you so much.
All right, so our program tonight will cover the latest in therapies and ulcerative colitis, new and emerging treatment, really with the hope that we have better days ahead for our patients with ulcerative colitis. And during this program, please make sure to comment and tweet your questions, your comment, and we'll do our best to answer your question live during this program. Over today's discussion, we are hoping to address the following objective: to apply safety and efficacy data from clinical trials of new and emerging agents, to achieve individualized and patient-centered IBD management, to analyze potential approaches for positioning new and emerging therapies for ulcerative colitis, and to evaluate complex clinical situations in which patients with IBD may benefit from management strategy, including new therapies. All right, so in true Monday Night IBD tradition, we will start our discussion with a case. This is a 27-year-old gentleman with left-sided UC diagnosed 6 months ago. On endoscopy, he had a Mayo score of 2, and he was started on prednisone, followed by mesalamine. He did well for a few months, but now he presents with a 3 weeks history of 4 bloody bowel movement per day, urgency. He wakes up at night to have a 2 bowel movement. He also complained of joint pain, mainly in the knees and the ankle. And on a flex sig, he has a colitis that now looks like a Mayo endo score of 3. On labs, he's slightly anemic. His CRP is elevated. His albumin is on the low side, but still hanging at 3.4. And his C. diff testing and stool studies are negative. So before we, I would love to hear Dana and Marla discussion later on. But before we do that, the question is, how do we assess a patient like this? So when we're looking at a patient with an IBD flare, with a UC flare, it's very important to look at the disease activity currently. And the ACG put out a new UC activity index that looks at 3 main elements clinically: how the patient is doing, blood work, hemoglobin, and markers of inflammation, and how the endoscopy looks. So in terms of clinical symptoms, the main focus is on the number of stool per day, blood in the stool, and a new element in this activity index is the urgency. This is really like a reflection of the severity of the proctitis. Then we're looking at the blood work, hemoglobin being low and reflective of active bleeding, and looking at inflammatory marker, either the sed rate, the CRP, the fecal calprotectin. So whichever markers you're comfortable with. Just a reminder that sometimes patients don't mount a CRP, and fecal calprotectin can be very helpful in assessing patient with colitis. And then an additional marker of disease activity that was added recently is really how the disease look on endoscopy. So whether you're using the Mayo Subscore or UCIS, it's important to assess the disease severity on endoscopy. And so for our patient, putting together the clinical picture, the labs, and the endoscopy, he's in the moderate to severe type of disease activity for his UC. So assessing disease activity in terms of symptoms, extraintestinal manifestation, biomarker of inflammation, and how endoscopy looks. And then it's important in terms of disease severity, really looking at how the disease course has been. And in this patient, very quickly, a few months after a prednisone taper, he had another flare. He also had disease progression. We moved from an Mayo score of 2 to an endoscopic score of 3. So this is important to assess how the patient is doing now and how the course has been. And for this patient, very quickly, he lost response to mesalamine, or maybe never responded to mesalamine. He was still having some prednisone effect there. And his endoscopy activity has evolved. And so putting all this together, it's important to assess what are the risk factors of this patient for colectomy. What are his risk of ending up with a colectomy at some point in his disease course? So risk factor for colectomy include age of less than 40, so young patients, extensive colitis, endoscopy score of Mayo of 3 or UCIS of 7. So this one you're seeing the deep ulcers, steroid dependence, a history of admission in the hospital, high CRP or SED rate, a history of C. diff infection or CMV infection. And it's always important to remember that UC is a progressive disease. And so activity and severity can change over time, and it's important to reassess this periodically. So now that we have our assessment of the patient, it's important then to decide what kind of therapy we need. So in our low colectomy risk patient, this is how our patient presented initially. Mesalamine, oral mesalamine with topical mesalamine are a good option. You can use budesonide to induce remission, and you can also use prednisone to induce remission and then maintain with mesalamine. But in our patient with a high colectomy risk, it's important to really move from the mindset of mesalamine to more effective therapy. So either steroid followed by thiopurine, or one of the biologic, vedolizumab, anti-TNF, or ustekinumab. And if you put the patient in remission, then maintain with that particular agent. If the agent that you chose initially does not put the patient in remission, then it's time to move to a different mechanism of action after reassessing what's going on in terms of inflammation. And we'll listen to Dana walk us through what to do after the first treatment if there's a treatment failure. But what's also important to remember is that even if your patient is in a low colectomy risk, but does not respond to mesalamine, or they have allergy to mesalamine, 2 to 3% of patients can have a reaction to mesalamine. It's important not to keep that stubborn reaction, to keep on the mesalamine, hoping things will get better. If mesalamine fail in our low colectomy risk patient, it's important to move them to the therapy that we use for high colectomy risk outpatient. All right, so a few more recommendations from our societies. Of course, systemic steroids are not a maintenance therapy. Of all the therapies that we have, that's often the discussion I have with my patient. Steroids are the one that carries a high risk of morbidity and mortality compared to other treatment drugs, and they are not, they're the least favorable choice in terms of maintenance. Thiopurine are effective for maintenance in moderate to severe UC. However, methotrexate is not a recommended therapy for ulcerative colitis. The anti-TNF that are approved for UC are infliximab, adalimumab, and golimumab. The newer mechanism of action, vedolizumab and ustekinumab, and tofacitinib. And in the recommendation, the recommendation is to use the lowest effective dose of tofa during maintenance. But now with tofa being approved only after failure of anti-TNF, we'll hear from Dana later on how to manage that and if decreasing the dose is really in the best interest of patients. So stay tuned for the rest. Another important recommendation is that 5-ASA can be discontinued when the patient is in remission on a biologic or small molecule. And I think it's very important to do that to minimize, polypharmacy and to simplify the regimen for the patient and decrease costs. So once we choose a therapy for our patient, how are we going to approach our care? What are our goals of care? Our main goal is to avoid serious complication from ulcerative colitis and avoid disability. So this is our main goal. And to achieve that, we need to predetermine certain targets. We need to predefine certain targets. These are going to be our goal, and we're going to treat to these goals, to achieve these goals. And in order to do that, it's important to reassess periodically the disease activity, whether by endoscopy or with inflammatory marker, clinical symptoms, and really adjust the therapy and optimize the therapy to achieve our target and our goal. And if the therapy we choose does not achieve these targets, it's important to reassess and change different treatment modality. But all these components, it's important to keep in mind in terms of the goals of care, the treatment, the monitoring of patient. All these need to be tailored to the particular patient and really be a shared decision with the patient and take into account the patient preference and the patient goals of care. So what are our goals in terms of treating patient with UC? The STRIDE-2, looking at selecting therapeutic target in IBD, really reinforce the fact that even though our first and our short-term target is symptomatic relief, symptomatic remission for our patient, our intermediate and long-term targets should be more ambitious. We're looking at normalizing the inflammation, at controlling the inflammation, and normalizing the CRP and getting the fecal calprotectin into an acceptable range. And we're looking for endoscopic healing. So beyond clinical remission, we're looking for biochemical remission and endoscopic remission. There are a few more targets that were added in STRIDE-2 compared to STRIDE-1, and I think they are really important to assess. One is normal growth in children, which is very important endpoint in caring for pediatric and adolescent with IBD. But also, I think that's really important for our patients, really listening to our patients. We need to restore the quality of life and prevent disability from the disease or disease complication. So I think looking at STRIDE-2, we really have a comprehensive target for our care for patients with UC. Now, histological healing is being considered, but it's not a formal target yet. And why is it being considered? It's because histological healing has actually been associated with a decrease in the risk of clinical relapse. So in a patient with histological inflammation or histological quiescent disease, there's still a risk of relapse over the years. However, if you have complete histological remission, your risk of relapse over the years is decreased. So it could become ultimately a target, but for now, we don't have enough data to really modify therapy just to achieve this goal at this point. How about endoscopic healing? Why do we talk so much about endoscopic healing? Well, it is associated with a decreased risk of colectomy in patients with UC. And you can see here a very large delta in terms of risk of colectomy in patients who maintain endoscopic activity at 1 year versus those who achieved endoscopic remission. So before we move to our panel, I wanted to put this slide out there. What is our data in terms of endoscopic healing with the different agents? We have for infliximab, the data of Act 1, with for Ustekinumab, the data of UNIFI, and the Octave sustained for tofacitinib. And for Varsity, we have the comparison between adalimumab and Vedolizumab. And what I want to highlight here is that if you look at the overall endoscopic remission at 1 year, the numbers seem to be very similar between different agents. But if you look at the delta, we see a larger delta between the treatment arm and the placebo arm, mainly with infliximab and tofacitinib. And I'll be interested to know later on what is the significance of that for our panelists in terms of choosing the therapy for patients with ulcerative colitis. So with this data in mind and with the guideline in mind and with STRIDE-2 therapeutic goals in mind, let's go back to our patient. So again, this is a 27, a young male patient, left-sided UC, a diagnosis with an endoscore of Mayo 2. Did well initially with mesalamine for a few months, but now comes with a moderate to severe UC flare with arthritis. His symptoms are really affecting his capacity to finish a day at work. The joint pain are affecting his daily activity. He's very involved in his kids' care, and he has a couple of young kids, and this is really affecting how he is able to connect and play with his children. He values convenience and he values a quick onset of action. He wants to feel better quickly. So I'm going to turn to my panelist members, Marla and Dana. And I'm going to start with you, Marla. How would you approach this patient? What are the factors that you take into consideration when you are choosing or discussing therapy for this patient? And how do you what would be your preference, and how do you, reconcile the guidelines with the patient picture and what the patient values?
Great. So this is where I've become after thinking all through it is I walk in, I'm thinking about it, and my first question is, does this patient earn infliximab? Now, what does that mean? Are there risk factors that say to me, I need a relatively rapid onset of action, so the need for speed, and whether they have the opportunity to be listed on for Vedolizumab, do they have Ustekinumab, do we have time, do we adalimumab, other options? So for me, when I see someone who's got systemic symptoms, he's got joint symptoms, granted, they could get better with just focusing on the colon itself, but not necessarily. We have someone waking up at night, so that to me is also a red flag. We have someone who worsened their endoscopic score despite therapy. And although convenience is important, which I completely respect, I'm still very focused on the most important thing is what is the best therapy for you to get you better quickly? And that's the way I approach it. So if the answer is no and I have time, then I can discuss other options with my patients. So that's my new sort of approach to patients with UC.
I actually really appreciate that. I think we always think about infliximab as being very effective, rapid onset of action, and really more just easier to kind of dose escalate and dose adjust to fit the patient need and the disease need. So I actually appreciate that the first question is, does this patient need infliximab? And if not, then move to what other therapy could help him. Dana, so let's say, do you think this patient needs infliximab? And if not, what are the treatment options that you think will be beneficial for this particular patient?
Yeah, I mean, I think it's a great point. And, if I can summarize that summary slide that you did, that you showed that everything was relatively similar in terms of the ceiling, right? So since we've had infliximab, nothing has done better. And frankly, for Crohn's disease or ulcerative colitis, despite all the agents we'll talk about today. So I think that it's a great question. And I don't think necessarily, I think there are options for this patient, especially looking at those pictures. I know we said it was a Mayo 3, but it was certainly, I've seen worse Mayo 3s than that. And so, there's some metabolic disarray, but the labs are relatively preserved. And so I really do undertake a shared decision-making approach. And I actually present my own summary slide of the different clinical trials and also talk about, the risks and benefits and the logistics. And so I do like to try to entertain the patient's notion of convenience or efficacy, et cetera. But ultimately, I think I have to advocate for the infliximab or the therapy I think is most effective. When possible, trying not to put forth my own opinion. I think in a patient here where we have extra intestinal manifestations, there's one thing that might steer me in the direction of a TNF antagonist. Might not have to be infliximab, but certainly, my decision making is really trying to involve the patient in that as much as possible, and then making a decision that we're both comfortable with, because obviously the medication the patient is going to take will be the best medication.
Right. And, we often talk about, when we think the patient values convenience, I think we often think about oral medication or sub-Q injections, but also I wonder if infusions are more convenient, every 8 weeks infusion as opposed to injecting or oral medication. So I think it's important to dig in more about what is convenient actually for a patient. But I agree that in this patient, I will probably go with a anti-TNF because of the arthritis. And I think this is really the class of agent where I had the best experience in terms of controlling the disease and controlling arthritis. I think that would be my first choice in this patient. I think if there are other concerns or other comorbidities that will benefit from other therapies, I think that might steer them in a different direction. Marla, you were talking about that if this is peripheral arthritis, it should get better with any therapy that improves the colonic disease. But has this been your experience? I feel like, the classic peripheral arthritis paralleling disease activity and any agent would help. Sometimes I scratch my head. I start to thinking, are the arthritis due to something else because they're not getting better and the colon looking really good? So I feel that sometimes the arthritis need their own, need a systemic therapy and something that will work for that. Is that your experience also? Are things different in pediatric population versus adult? I would love to hear both your thoughts.
Yeah, no, good question. I think this does require some thought here when we talk about arthropathies and arthralgias. There's two forms we need to focus on. One is the true synovial, whereby an anti-TNF and or a JAK inhibitor would be appropriate, true rheumatoid-like arthritis. But the majority of arthritis that we see is more of an enthesitis. So it's where the tendon actually inserts into the bone, which is very akin to a psoriatic arthritis, which is this enthesial. And to be fair, that's why, Ustekinumab, for example, does not manage true rheumatoid arthritis. So if you should understand the difference, because there is a difference in treatment approach. We think, oh, it's approved for arthritis, Usta, for example, but it's for enthesial type of arthritis. So we have to be very clear as to what we are managing. And so, for example, distal joint may be very, multiple sort of distal digits will be more psoriatic type than someone who's got a swollen knee with a synovial effusion. So it is important that not all arthritises are the same. So thank you for bringing that forward. And it does make a difference as to why we see some patients on Vedolizumab who continue to have arthritis or arthralgias, because we are not addressing maybe a peripheral entity. So it does require partnership with, I think, rheumatology more than we think we should, by the way, and an early referral to collaborate with them, because they've taught me a lot in the differences between them.
Yeah, absolutely. I mean, I'm actually wondering in this patient, if you have a patient with a severe joint pain, do you ever consider, a first line using, adding like maybe a methotrexate or sulfasalazine? Does this help in your experience? I would love to hear your thought, both Marla and Dana.
Yeah, personally, we do think about this a lot, and I think. Right. So while we've mentioned that methotrexate is not necessarily the agent we want to use for primary therapy of ulcerative colitis, I think, I do involve a rheumatologist very, very closely in many of our patients for this reason, because I think we want to think about methotrexate. Obviously, for many reasons, that's contraindicated for some of our patients. And so I have used sulfasalazine in some patients with milder joint symptoms, et cetera. Would we want to consider in a young, healthy patient with no cardiovascular risk factors, even tofacitinib in this case, which wouldn't be unreasonable if this patient values convenience? Maybe that's something that we could work around the current rules here, to get this patient an appropriate therapy. But I definitely think that we have to remember that just because we're placing this patient on a primary medication, that there might not be other roles for combination therapy and other management. It may not have to be full dose, a combination, but certainly something to help out.
So the other thing I learned is sulfasalazine doesn't work well for sacroiliac inflammation. So that, again, it's like, that's why it's amazing how low back pain is one of the most underdiagnosed or things that we're actually aggressively searching to help our patients. And we're like, oh, we'll get better when we manage your colon. It's actually not often getting better. And I think, like Dana suggested, these may be patients where you may want to do some sort of combination with, perhaps not a TNF plus a JAK, of course, but I'm saying maybe like a Ustekinumab or a Vedolizumab plus a JAK inhibitor. And I think, following, and we'll talk a little bit more about the newer JAKs, emerging therapeutics, for example, but I think the future needs to think broader about the various inflammatory pathways we need to be hitting hard up front, and then maintain maybe with a difference. So I think sequencing is important, and I think we'll figure this out as we understand how each of these therapeutics fit within each other.
Absolutely. Well, this was a very exciting discussion to start. We're going to get moving. So, a few things we discussed with Marla and Dana, how to choose a therapy, a few things to consider with the first choice of therapy. So as a general guide, we all know that the first therapy we're going to use for the patient is going to be the most effective. So this is where really a lot of thought process has to go into that, really looking at the overall picture, the efficacy, the safety, and the actual intestinal manifestation. And like Marla pointed out, for severe UC, even if it's not the inpatient UC, but for more severe UC, more patient at high risk of colectomy, infliximab is still a preferred treatment choice. We have great experience with it. There's a rapid onset. It's very flexible in terms of dosing. If your patient has a low albumin, think about tofacitinib or maybe tacrolimus, because these are non-protein based therapies. For extra intestinal manifestation, again, figure out what kind of, is it axial arthropathy that that does not respond to colonic remission that requires, its own therapy, like with anti-TNF or TOVA, or these arthritis, synovitis, think about the agents that would affect the joints also. Maybe an older patient or patient high infectious risk, Vedolizumab or Ustekinumab would be better agent. And think about comorbidities. So psoriasis, Ustekinumab or anti-TNF are both on label and could be beneficial for the patient's condition. So looking at that, our patient chose to start adalimumab. And he did well with maintenance 40 milligram every other week for a few weeks. And then he actually required dose escalation to 40 milligram every week because his symptoms were recurring at day 10. And then on this regimen, his GI and joint symptoms were in remission. And he was in endoscopic remission at a last colonoscopy 6 months ago. But now he presented with a flare with 4 to 5 loose bowel movement per day and blood for more than 50% of the bowel movement and urgency. So Dana, I would love it if you walk us how you evaluate a patient who's losing response to an anti-TNF or a first agent. What is the role of therapeutic drug monitoring, and how do you choose the next agent after a failure of an anti-TNF?
Great. Well, that was a really nice introduction. And I think, this patient is a very common patient. And I'm thinking about this patient. I'm a little bit worried now that this patient has lost response to their first agent, especially after noting that very early on the patient needed to escalate therapy to weekly adalimumab. And I think that, we have to think about when we're talking about disease severity, in addition to the current activity, that this places that patient in a higher risk group, right? And so once a patient does lose response to their first agent, in this case a TNF antagonist, I think we want to think somewhat algorithmically as to why this patient now has active disease. So if this patient now has breakthrough or recurrent symptoms on their TNF antagonist, is this actually from inflammation or is it something else? And this is the primary question, and it needs to be answered objectively. First and foremost, if there is no endoscopic inflammation and the biomarkers are normal, well, then what are the other causes that we should look for? Obviously, infection, C. diff, and CMV being the primary drivers, but other gastrointestinal infections may be something to consider. And in their absence, then we have to think, okay, why did this patient now who had a response to a TNF antagonist, why did they lose their response? So in the case of a primary non-response, we're not talking about this current patient, but this is a patient who has started on therapy and never had an adequate response despite adequate drug levels. And so if that's the case, we're thinking, okay, we need to switch not another TNF antagonist, but out of class. Now, if a patient like this patient did have a secondary loss of response, meaning they've achieved endoscopic remission for a couple of years and then all of a sudden relapsed, well, now we want to understand why. And this is where our therapeutic drug monitoring becomes very useful. So number one, does this patient have adequate TNF drug levels and negative anti-drug antibodies? And if that's the case, then we call this a true secondary loss of response. And this really tells us that the mechanism of TNF antagonism is likely not going to be effective for this patient. Therefore, we're going to switch to a different class. In the middle case here, where there's a low drug level without antibodies, or maybe with a low level of antibodies, debatable whether all antibodies can be overcome, but certainly if there is a low level, then one might think of dose escalating, either the dose and or the frequency, and I would add, in the case of low levels of antibody, combination therapy with a thiopurine. For the case where there is inadequate drug level and there's high levels of antibodies, that gives you the most flexibility in terms of what you might be able to do next, and that's an in-class switch to a different TNF antagonist with or without an immune modulator, right? So if they have antibodies, they're very likely to be antibody formers to other TNF antagonists, and we might be able to figure this out with understanding their HLA-DQ subtype, haplotype, and so we might be able to check this and figure out if we really want to do combination therapy for the next agent, or you have the option to switch out of class. So while we're talking about therapeutic drug monitoring, I think, certainly for the TNF antagonists, we have the highest level of data, and I think we want to think about what are the recommended levels of and at different time points. So the AGA does put forth maintenance guidelines for infliximab at greater than 5 micrograms per milliliter and adalimumab for 7.5 in the maintenance phase. The Bridge consensus group has actually gone over this at various time points, which is very helpful. I think, when you're inducing a patient, obviously the levels should be higher than in maintenance. And so you can see, weeks 2, 6, and 14, there are different thresholds which go down over time, and slightly different cutoffs. But if you look at different endpoints, I think in different studies and the way, depending on way studies have been conducted and designed, there are different results. And so looking at just a clinical response and remission endpoint, one study has shown that a target of greater than 3 is sufficient with infliximab. But if you're looking for mucosal healing, we know that you need more drug on board. And that's a common theme, depending, regardless of most medications, as well as Crohn's disease or ulcerative colitis. For adalimumab, the Bridge recommends that at week 4, you should have a level of of more than 5. And if you're looking for mucosal healing, again, that 7 to 8 range is appropriate, and certainly not to switch until you've achieved a drug level that's over 10, right? So I think one of the biggest pitfalls of therapeutic drug monitoring is, okay, this patient has an adequate drug level. Well, not every drug level is the same for every patient. Just because the recommended range is 7.5, maybe this patient needs a little bit more. Maybe it's a patient like the patient we've presented here who has a very high inflammatory burden and just needs more drug. So there are other recommendations that have been presented, and you can see these in the right side, where we're looking at biomarker and endoscopic and radiographic co-monitoring of therapeutic drug monitoring, and higher levels of 10 to 15 for infliximab have been suggested. I'm going to not mention all of these studies, except to say there's one study that looked at optimization of infliximab concentrations. And if you looked at those patients who were able to achieve a higher infliximab concentration after optimization, that was associated, every half a microgram per milliliter was associated with endoscopic healing. So very important that if we're doing this, just to look at the initial level, it might be a good idea to follow serial levels and make sure that you're actually making a difference. And so I'll let you read over the remainder, but I'm going to move to the next slide. So when we're talking about our treatment choices, now that this patient has lost their response to adalimumab, we obviously have our 3 major classes here. First is our conventional therapies, such as steroids, aminosalicylates, and immune modulators, which we've already discussed that this patient has really too moderate to severe disease, much more advanced disease than is going to respond to these. And so we're really looking at the biologics and small molecules. We've talked about our TNF antagonists already. And so I'd like to talk about some of the newer classes which have been FDA approved. And these are the anti-integrins, which includes vedolizumab. And this is a quote unquote gut selective molecule, which prevents trafficking of the immunoreactive lymphocytes from the circulation to the gut by blocking the interaction of alpha-4 beta-7 integrin on the circulating lymphocytes with MADCAM on the vascular endothelial cells of the gut. Also, we have the anti-IL-12/23 antagonist Ustekinumab, and this class of medications basically prevents signal transduction pathways, and some of my colleagues like to call this inflammation specific, because these pathways are upregulated in inflamed tissues but not in normal tissues, so they may not have as broad a immunosuppressive profile as the TNF antagonists. On the small molecule side, we'll talk about JAK inhibitors, of which tofacitinib is currently approved. It's a oral pan-JAK inhibitor. And we recently, just about a week and a half ago, had the approval of our sphingosine-1 phosphate receptor modulator, ozanimod, which Marla will talk more about in the next section. So we're talking about a patient that is now treatment exposed, not our treatment naive. And so one of the questions about our medications in their development program is, okay, how does a patient do if this is first-line therapy as compared to if this patient has previously been exposed to other therapies? And in the case of most of our medications, we're comparing to TNF antagonists. So if you look at patients who were treated with induction therapy with adalimumab and then maintained out to week 52, you can see that clinical remission and clinical response are highest among patients who are naive to TNF antagonists. You see that the clinical remission rates after induction is about 21%. And if you follow this out to a year, maybe slightly higher, but it certainly is maintained that the patients that have prior TNF exposure do not achieve higher rates, as high rates as those who are bio-naive. Looking at vedolizumab, the same holds true. If you look at week 6 and week 52, in the left we see patients that are TNF antagonist naive. You can see that at week 6, the overall response is about 2-to-1 in favor of vedolizumab over placebo, whereas that's the ceiling is a little bit lower for the TNF failures at 39%, and although that 2-to-1 ratio is preserved. If we're looking at remission at week 52, similarly, there's a higher ceiling in those that are TNF naive as compared to those that are TNF exposed. Remember, those who went to week 52 were responders at week 6, and therefore we may be seeing more of the treatment exposed patients with a response out to week 52. So speaking about treatment exposure and disease duration, we know, or we believe at least from several studies in Crohn's disease, that longer disease duration is associated with worse or lower response rates to various therapies, and that there's cumulative bowel damage that may be irreversible. It's long been thought that maybe ulcerative colitis is somewhat different, and a number of studies have failed to demonstrate that patients starting earlier versus late will have different disease courses. So this study is comparing an early population, and the early group, which was 59 patients, was patients that had been on conventional mesalamine or corticosteroids, but not immune modulators and not biologics. The late time point was 4 years or later, and those patients had all been previously exposed to immunomodulators or a biologic agent. So not quite, so we're looking at disease duration as well as treatment exposure. And so the primary endpoint here was the proportion of patients that had a sustained remission at weeks 52, 26, sustained remission, which is at both time points. And this is an intention to treat analysis, meaning all patients that were in the group were lumped together. And you can see that there were no statistical differences between the early group and the late group. If you look at some secondary endpoints, which are remission rates at either week 26 and 52, there was no major difference. And if you look at endoscopic improvement, either using an intention to treat or a per protocol population, that there were no differences between the early and late population. So this is very interesting. However, there was a high dropout rate, and we're not comparing exactly equal populations, but it does suggest that like a popular belief that there may be less of an impact of disease duration on treatment outcomes in ulcerative colitis. So we just talked about 2 agents whose efficacy is decreased after prior biologic exposure. Interestingly, the next 2 we'll talk about are not decreased following biologic exposure. So with Ustekinumab, we look at 2 different populations. On the left, you see the biologic naive patients, and then the biologic failure group, which had either exposure or true failure to respond to a prior biologic. And looking at induction outcomes at week 8, you can see that in terms of clinical remission and clinical response, the curves look very similar, and the delta of differences between Ustekinumab and placebo are virtually identical between the 2 cohorts, a slightly lower ceiling effect in the biologic exposed group, suggesting that Ustekinumab may be intrinsically different than adalimumab or Vedolizumab in that it may not have diminished efficacy in biologic failures. Speaking of Ustekinumab, so we're talking about using these in the real world. This was a nice cohort study out of New York showing a cohort of about 47 patients that had been exposed to ustekinumab, and most of these patients had been on one or more biologic agents prior to ustekinumab treatment. And you can see that at 12 months, almost 45% had a clinical remission. And all of the outcomes studied here were relatively robust when you look at the clinical trial data that we're comparing it to. Mucosal healing in about a third of patients. And so in a true refractory population, ustekinumab is performing well. Obviously, these are retrospective data, and this is not placebo controlled, and so this is very much a real world study, and patient selection may play a role, but it does suggest that when we're using these medications and we're choosing them for a reason in the real world, we are seeing robust efficacy. Let's comment on the safety of ustekinumab. I mentioned that it wasn't, it was possibly less systemically immunosuppressive than the TNF antagonists. If you look at the labeling, there certainly is the possibility of infections and a number of complications. And so this was looking at cardiovascular safety with ustekinumab in one of the in the long-term safety trials from rheumatology. Or from dermatology, with ustekinumab, there was a suggestion that there might be cardiovascular adverse events that were higher in ustekinumab as compared to placebo. In this study, if you look at patients with a mixed population of Crohn's disease and ulcerative colitis, and in the right combined IBD population, where roughly twice as many patients were on ustekinumab as compared to placebo, the event rates for major cardiovascular events were very similar between ustekinumab and placebo. Looks like, in Crohn's disease, there may be a slightly higher risk, and ulcerative colitis, this is lower. So I mentioned the second class that whose efficacy is not diminished with TNF exposure, and that's tofacitinib. So if we look at results from the registration trials here in the Octave 1 and 2 studies, you can see that both for the outcomes of clinical remission and mucosal healing, those patients who are TNF naive and TNF exposed have a very similar difference between the tofacitinib and placebo. You will note that the overall treatment effect size is a little bit lower in those that are TNF exposed, and that's a common theme with most of the medications we look at. So Aline hinted at this before when talking about the recommendations for tofacitinib. We obviously know that there is some potential for adverse events, and we know that the guidelines suggest that we induce with 10 milligrams twice daily for either 8 or 16 weeks, and if a patient is able to achieve a stable remission, then we dose de-escalate to 5 milligrams twice daily and try to maintain on the lowest effective dose. So what happens if you actually look at this systematically? So in the riveting study, they're looking at clinical remission rates at 6 months, and these are patients who were in a stable remission on the 10 milligram dose for more than 6 months and then de-escalated to 5 versus those patients who did not de-escalate. And so if you look at the different outcomes here, looking at their overall clinical remission rates, you can see that 10 milligram certainly outperformed 5 milligram from 90 to 77%. And among those patients who had lower endoscopic disease, Mayo 0 and Mayo 1, much higher proportion were achieved that on the 10 milligram dose. If you look at by prior TNF exposure, really doesn't make a difference. And this reiterates what I showed you a few slides ago, that the TNF exposure is really not as relevant for TNF for tofacitinib. But it does suggest that there is some risk to lowering these patients down from 10 to 5. And so I think a lot of experts have really been maintaining that one should carefully consider in whom it's safe to de-escalate those doses. And so for many patients, including a refractory patient like this, it might be the best strategy to maintain that patient at 10 milligrams rather than trying to de-escalate. talking about the safety of tofacitinib, many data coming out of rheumatology with the signal for potential signal for thromboembolic events and even mortality. Well, if we look at some data out of DDW this year presented by David Rubin, really reassuring data that no new safety signals were seen. Most commonly reported infectious side effects were clostridial infections, including C. diff, as well as pneumonia. Obviously, this year, COVID-19 was one of the more common adverse infections. And looking at thrombosis and DVT, we see that these rates are fairly low, about 1 out of 100 person years. And PE is slightly lower than that. And very low incidences of neoplasm and cardiac adverse events. So I think very reassuring. We still want to make sure that we are carefully selecting our patients. Many of our patients who are older, increasingly older population, who have had cardiovascular risk factors or prior thrombosis or maybe have a hypercoagulable state, I think we want to carefully consider whether or not TOFA is a good choice for them. And similarly, possibly patients who are on estrogen or high estrogen contraceptive methods, which might be at increased risk as well. So just think about which patients carefully that we're going to choose this for. Lastly, I want to just mention a very cool study that was presented at DDW and has since been accepted to clinical gastro and hepatology, looking at the use of tofacitinib in acute severe UC. So if we look back at the literature, we have very good data that shows that infliximab as a salvage therapy is very effective. And so same thing with cyclosporine. What about for patients who have been exposed to biologics already? Maybe they have contraindications to infliximab therapy. Well, we want to see other options. And so this study looked at a really nice design where they actually gave patients at the discretion of the treating physician tofacitinib as an inpatient, and they're comparing versus corticosteroid therapy alone, so IV steroids plus tofacitinib, and this was 10 milligrams 3 times a day for 3 days, then twice daily dosing, versus a 10 milligram twice daily dose versus steroids alone. And they also used some historical controls. These curves are identical. If you see two curves, if not, there's so it shows that the TID dosing was significantly less likely to require colectomy. So the colectomy avoidance rate was highest in the TID group, whereas there was no difference between the BID dosing and the corticosteroid alone. And so this tells us that maybe for some patients that tofacitinib might be a nice strategy. Obviously, these are observational data. This is not a controlled, randomized controlled trial. And there's certainly smaller patient numbers, but it does suggest that maybe there's other ways to think about salvage therapy. We know that tofacitinib can work in as little as 3 days, and their earlier data suggested that 15 milligrams dosing might be appropriate for some patients. And so therefore they wanted to minimize the risk of prolonged TID therapy, but also harness the potential rapid effect and certainly albumin independent effect of tofacitinib. So I'd like to throw it back to the group here and just have a discussion on what we've been, all of these newer therapies, obviously not the newest therapies that we have, but therapies that we've been using for a couple of years. How do these newer data really influence how you are thinking about this decision we have to make for this patient? I guess we'll start with Aline.
Thank you, Dana. That was a very elegant presentation. I'm going to, and thank you for presenting, some of the most exciting data from DDW. I'm going to tell you, I was mostly excited by the TOFA data in acute severe UC because it always gives me palpitation to use cyclosporine in patients who have not responded or failed infliximab. So I'm happy that we have another option. And I think it's interesting to see that we kind of exploring different indication for the therapies that we have now available. And I think high dose tofa will be a great option for patients who have either failed infliximab, but also for patients with very low albumin, we know do not respond to infliximab. They're basically pooping out the infliximab as they're pooping out the protein. So I think I was really excited about this data. And I think one of the interesting things is that even though in this population with severe UC, and we know that acute severe UC patients are at high risk of hypercoagulable, they're in a hypercoagulable state, right? It doesn't seem, I know it's a small number of patients, but it doesn't seem that the high dose of tofa increase the risk of DVT and PE in these patients. And the data that you presented on tofa safety was also kind of very reassuring. And I think that really between the tofa safety data, comparing what we saw in RA and what we're seeing in UC, and also with the Ustekinumab, between the data that was in derm, maybe there was a signal of increased cardiovascular event in patients with cardiovascular risk factor, but we're not seeing this in IBD. I think it really highlight the importance of studying the drug in the disease that we're treating, that it's hard to compare. But also I think I'm excited by the safety, because that's so important for us to be able to give these, to have these treatment available for our patients that are more difficult to treat. So I'm going to leave it at this. I have much more questions for you, but this is really what, from the data that you presented, what got me really excited, and I would love to hear from Marla.
Yeah, I think one thing that comes across for all of us who manage IBD, I want everyone to understand that sequence will matter. I'm still going to stick to my message. I'm very consistent. That I think understanding, and Dana did an amazing job of highlighting which therapies may not do as well if you have seen a TNF, which goes back to the case. It's like when you're making a commitment to a TNF, recognize you may need a second move, right? So I think part of it is already anticipating, reassuring the patient what we know, because patients are very fearful, like, what if this doesn't work? They haven't even started the therapy. What if this doesn't work? What do I do next? So I think being able to, reassure patients about what we do know about the safety of efficacy of the therapy, but then also understanding what Dana presented. Knowing what would come next is really important, because we also want to understand that to anti-TNF exposure, and why Dana made a point that maybe this individual may not need a TNF, and you and I were talking around that, is there's a reason. Because if there are other options on the table, we know more Crohn's than in UC that certain drugs do better. Like Vedolizumab, it was clear from Varsity as well as from the GEMINI program, if you have failed an anti-TNF, it does not do as well. Right? We understand that. Listen, adalimumab, if you look at sequence data and you look at Sid Singh's network meta-analysis, then if you failed an anti-TNF, like infliximab, there's absolutely no role for adalimumab or golimumab in a patient who's failed infliximab. I want to make that clear. I don't want to see people failing infliximab and then getting another TNF. Let's move on. The question then remains is it Usta, Vedolizumab, or Tofa? And I think what Dina showed is that if you were going to pick a winner, a horse race, you were a betting person, you would bet on either Ustekinumab or tofacitinib, because those seem to be, I say, agnostic to, or, to TNF failure. Obviously, any drug does better if you haven't failed TNF. I don't want to make it seem like it's a magic. But I think understanding that when you are making that critical, important decision is important. And half of it comes back to how quickly do you need effect? We know that tofa does indeed have a much faster onset. I'll talk a little bit about that with the new therapies as well. But we need to be clear on our choices and make it communicate clearly to the patient what their expectations are. So I think that is what I learned, Dana, from like your whirlwind tour of all of our, of our next set of therapies. And I'll take you on even more of a whirlwind of all the amazing new stuff, including ozanimod.
I really agree, Marla. I often see patients who have not responded to infliximab and they get started with adalimumab and it doesn't make sense. But then my question to you is the reverse. If somebody did okay on adalimumab or didn't respond to adalimumab, do you ever go to infliximab? Or does this depend on your drug level or on the situation? If there's somebody that's really sick that you feel infliximab is a drug for them and they didn't do well on adalimumab, when do you go from adalimumab to infliximab?
Yeah. So again, I think if you have a patient, and you highlighted, because you know my obsession, but on the therapeutic, on the, you know, the pharmacokinetic of it, and a patient who has low albumin, high CRP, hasn't done well with ADA, I'm not so sure that going to a JAK, to be fair, going completely, like Dana was noting, going out of this biologic-focused PK issue and hitting it hard with a JAK small molecule where we don't have to deal with any of that. I think that it all depends on how sick the patient is and whether there were anti-drug antibodies. Then I think the world's open. If it was an anti-drug antibody to ADA and the patient was not a bad responder, I think Remi is, infliximab is a great option. Again, comes down to speed, patient preference, convenience, compliance. So I think both of you have highlighted so much how it is not unifocal. If we really want to practice the art of IBD, we have to be creative and understand the literature and really be able to communicate correctly to our patients.
Absolutely, absolutely. Dana, I want to go back to you in terms of the trough level and therapeutic drug monitoring. And it's always I think there was a lot of excitement when we start talking about TDM. That's going to be very clear for us. You get this level, you do this, and you get this. Everybody needs to be in a certain range. But then as the things were evolving and we're getting more data, first of all, the level kept changing, kept moving, right? So we were like, infliximab more than 3 is great, and now it's more than 7, more than 10, you can push to 18. Same with adalimumab. And I think a lot of confusion comes out from this. And also added to this is that often when you get your lab report, right, it would say, it would use some, therapeutic number that is way below from what you presented today for both adalimumab and infliximab. So few things that happen, I often see patients or physician abandoning a therapy before optimizing the level based on this, like, it's, infliximab, around 4, and that's therapeutic, and it's not. But also, so I would like to hear your thoughts on that. But also I was wondering, one is, when do you check levels yourself? Do you check on all your patients proactively? Do you check during induction or maintenance? We all check reactive, but how about proactive? And how much are you ready to push for a level? If your patient has some kind of response, a good response, but let's say they have an infliximab level of 12, do we push for more? If there's an adalimumab level of 12, do we push for more? So that is my question. Well, these are my several questions to you.
So for the next hour, I'll be talking. I think it's obviously complex, and there are many non-believers in TDM, and there are many true believers. And I think this is a lot of where the art mixes with the science here. Clearly, there's a role for TDM with TNF antagonists. I think that's not debatable. And reactive testing is by far my most common method in clinical practice because it makes sense, right? We have these algorithms where we've showed you that it really helps to make clinical decisions. I think, another place is right there, right? So what if you get this level that's close to what the guidelines are suggesting? Well, the patient doesn't read the textbook, right? And I tell them all the time, my patients, that, you didn't read the textbook. This is you. And so just because there's a probability or, an area under the curve that suggests this level, that doesn't mean that's what you need. We know from fistulizing Crohn's disease, sometimes you need a level of 18 or, over 15 to get a true response. And so, if it makes sense that maybe increasing would help, then I think it's worth thinking about, but not always, right? If you've got a level that's 20, I don't think that increase, even if that person's on every other week dosing, that maybe you're not going to get extra bang for your buck there. And so I will do proactive testing, especially in patients that have prior antibodies. I think that's one population where I'll do it at least post-induction. So usually either week 6 or week 14, with infliximab or and then maybe around week 8 for adalimumab. In an ideal world, obviously patients come in when they come in, but that's my goal. And then, I like to check to make sure that on maintenance, at least, once that they're at a good level. And then I switch to more of a reactive strategy.
Yeah, I think my practice is very similar to yours, and I've used some tips, and I'm going to use some of the tips you shared with us today. So I'm going to let you, Dana, summarize, your section, and then I'm looking forward to Marla presenting recently approved therapies and emerging therapies for UC.
Great. So I just have two more slides to discuss, one of which you mentioned Sid Singh's network meta-analysis. And so this is a very interesting way to look at clinical trial data. So it's trying to do a relative comparison of clinical trial results. And so obviously the different populations are a little bit different to one another, and the designs of these trials is different. But if we're looking at patients that have undergone induction therapy with all of the FDA-approved therapies. You can see them summarized on the left in a biologic-naive population, and those with prior TNF exposure on the right side. And you're looking at a value called the SUCRA, which actually, the higher you get, the closer you get to 1.0, that's the perfect medication. If it worked in 100% of the patients, 100% of the time, right? And so you can see that infliximab gets pretty close to that as a first-line agent. Unfortunately, we don't have any studies that looked at infliximab after TNF exposure, because it was the first and really the goalpost by which we're judging all these other therapies. But so you can see that in biologic-naive patients, infliximab really does still continue to be the gold standard. But if you look at vedolizumab, and in fact all of these medications, they do relatively well as first-line therapies. You mentioned positioning of these therapies, right? So all of these therapies work great in a lot of patients, and I think you have to choose which patient it's correct for. But if we're thinking about what works best as a second-line therapy, well, we now have some emerging data that we didn't show, the Evolve studies, right, that suggest that if you use vedolizumab as first-line therapy and then go to a TNF antagonist, either in Crohn's or UC, there's no difference in terms of the efficacy of the TNF antagonist. And so I think it might be a nice strategy to say, okay, well, which hand do I want to play first here, especially if the patient prefers it or if the patient is more of a moderate disease. If we're looking at patients with prior TNF exposure, as we presented the data before, ustekinumab and tofacitinib are clearly ahead of the others that are available, right? So either adalimumab or vedolizumab. And so in that case, we, a TNF exposed patient, we really want to think about those two realistically. And so just looking lastly at, sort of what other factors we might want to think when we're considering a switch, right? So as we mentioned, with primary TNF failures, then we're going to switch out of class. And because vedolizumab is not the best option there, we're going to do ustekinumab or tofacitinib. If a patient has a lupus-like reaction to a TNF, obviously we want to switch to anything that's not a TNF. And we can base that based on the patient's, disease activity at the time and their severity. If a patient has a anti-drug antibody to one anti-TNF, we certainly can do combination therapy with a second TNF or switch out of class. If there's joint pain on a gut active vedolizumab, then switching to either tofacitinib or TNF antagonist would be both on-label indications and worthwhile. If a patient develops anti-TNF induced psoriasis, I think, obviously ustekinumab is indicated for psoriasis and makes a great choice. However, just stopping the TNF usually is sufficient once it's washed out to stop these things. And so you probably could choose either tofacitinib or vedo in those situations, but there are no data to really support these. And so these are based on clinical experience. And lastly, in a patient with a new cancer, especially a solid tumor, one could consider using vedolizumab or ustekinumab. Again, if a patient has very severe disease, you really have to talk about those benefits and risks before you absolutely choose one of those if a patient is has very severe colitis. But obviously, we want to do something that has the least potential for adverse events. So with that, I'm going to turn it over to Dr. Dubinsky, and I'm really looking forward to you presenting the recently approved S1P modulators and the newer classes in development.
Great. Thank you, Dana. I think you sort of, with that sequencing slide, I think we'll have to update it with some of the newer data. So it's a good foundation upon which to describe sort of where we are in the landscape. We talked, you noted, and everyone's talked about ozanimod as being the first S1P, which is an S1 5 receptor modulator within that class. Etrasimod is still under investigation. The JAK inhibitors, you talked about TOFA. So I'm trying to make a sense to everyone that this is sort of, there are some that are next generation and some that are completely new. And I think that's what's exciting right now. So in the JAKs, we've got the filgotinib, JAK1 inhibitor, upadacitinib, JAK1, and then this the TD1473, which is a gut-restricted JAK. The anti-IL-23s are very exciting as well, risankizumab, mirikizumab, and guselkumab, and then the integrins, etrolizumab, and entolimab. So that is also the anti-MadCam one. So this is where the landscape sits right now. I'm going to walk you through all of the induction data that we have for the newer JAKs, but also walk you through, obviously, the induction and maintenance that we have for the data, particularly ozanimod. So as we look to I think there's one slide before this, sorry. As we look to the True North, which is the induction data for ozanimod, just to present, this is the which was part of the clinical trial program that led to approval. The reason why this slide is important, it feeds completely what we were saying about sequence matters. I do want to focus a little bit on the difference in the data of a patient who got ozanimod in induction, who had failed prior anti-TNF, or had never seen. And I think what's important, Dana, that you mentioned is that when you start, everyone needs to understand that where sequence matters is induction. By the time you get into maintenance at any of these trials, these were people who already made it to induction. They were responders at the end of induction. So you can't necessarily say at week 52, this had anything to do with what happened 52 weeks ago. So I think why I like people to understand that sequence matters, particularly for induction. As you can see here, if you look for where there was significance in prior TNF failures, the only area of significance was response. I want everyone to remember what I'm saying here. In patients with no prior TNF failure, you see all those lovely zeros. You know, there was a lot of significance across all the outcomes. So again, it will fit with what Dana's discussion and what we talked about is it may matter when you introduce ozanimod, because like we always do, when new therapies come on, we're ready to throw a Hail Mary after they've failed every other therapy. And we're like, oh, there's a new target. This drug is going to work for you. Just wait till that comes out. We have to, again, understand the data and know where our drugs work best. On the next slide, we're showing you the speed. Because again, with the speed concept came in for TOFA, I mean, what we didn't show is there was that post hoc analysis for tofacitinib showing that like over the weekend, your patient has significant improvement, meaning day 3, there was a reduction in stool frequency and rectal bleeding, and that was because there were daily diaries. And this was obviously not part of the label for TOFA, but was a post hoc analysis. Part of the data we have from the trial right now, this is just showing you that already at week 2, which again, doesn't mean it doesn't work earlier. It's about when we first look at the data. So I want everyone to also appreciate that often data points is when we look. It doesn't mean that it wasn't there. So just to keep that in mind in terms of whether or not there's a speed, this is what we know, 2 weeks. On the right is just showing you that when we did break down all of the modified Mayo or looked at the components of the Mayo score, the 2 things that were important to know that patients want to know, my rectal bleeding score and my stool frequency score. And it's just showing you that across the board, these individuals met those outcomes. But again, the whole population may have been driven predominantly by TNF naive patients. So let's be clear on what we're talking about when we talk about choosing the right patient. On the next slide, what we show here is, again, looking at the week 52 data. I sort of gave you a preview of my mindset about what prior failure looks like when you get all the way out to maintenance. And that's, again, as a reminder that everybody that gets beyond induction were responders. So they made it past the tough part. And as we know for a lot of our drugs is when you make it in induction or responder, we tend to have better durability. And we're seeing that with a lot of our therapies. So the key is getting the right drug, getting them in past induction. So here it's just showing you across all the time points, whether you were naive or a failure, that once you made it into maintenance, the good news is that it met all of its outcomes, including mucosal healing. I do want to differentiate the mucosal healing definition for MOD was the highest sort of bar we've had in a label. And that was because we were looking for endoscopic improvement, a Mayo score of 0 or 1, plus no histologic inflammation, You heard what I said. This is a very, very strict sort of threshold here. And you could see that this drug made it at week 52. These are important concepts we need to start thinking about, is how high we're now asking our new drugs to jump, you know? So, and it seems like we keep getting higher and higher and our drugs keep making it. So this is like amazing, you know, to see all this data, but just, I always want folks to keep in mind who's the right patient for the right drug at the right time. Important concepts as we review. On the next slide, we start to get into a little bit about the safety. Just as a reminder, the table on this slide shows you sort of the more common and incidence rates of the actual frequency. But again, Dana sort of talked a little bit. He showed Dave Rubin's slides on per 100 patient years of follow-up, because it's not just a frequency. You also have to match that to the duration of exposure. In the old school way, we looked at N and frequency and we're like, that's the frequency of these side effects. It's always good to frame it in 100 patient years of follow-up. Either that's one patient followed for 100 years, which of course is not, it's not possible in this scenario, or 100 patients followed for 1 year. So that's how we sort of have to conceptualize the total number of patient years. So this shows you in the context of within the ozanimod as well as the placebo. One thing of note is over time, it seems like any adverse event we see with a lot of these newer therapies happens at the beginning. And then those people who are tolerating it and stay on and are doing well tend to have less side effects over time. I also want to remind everybody that one of the most common side effects of any therapy, for some bizarre reason, which I still haven't figured out, is just loss of efficacy, meaning worsening of the disease. So really, I think when you want to look at safety, I would take out a little bit thinking about worsening IBD as what we're really looking up for, is because we have high expectations that that's what the drug efficacy is about. You really want to focus on treatment-specific adverse events, and the ones that matter to patients are serious infections, for example, are what we really need to be focusing on. Remember, in a one-year trial, we are not going to see rare events. Please remember that when you're assessing clinical trial data, we typically don't see rare events, which is why we're still seeing new things 20-something years later with our TNFs, right? So there's something to be said about longer-term follow-up, but what we want to make sure is what are the most common things we need to tell our patients that we saw in a clinical trial. So that was sort of the messaging around ozanimod. There's a lot of reminders that patients will need an EKG before they actually start ozanimod. So there is a learning curve here, folks, for ozanimod, and this will be all part of a safety checklist. And of course, we'll update our cornerstones checklist like tomorrow, you know, to be able to make sure we actually have all of the information. But it is important that you understand what are the things patients need before they even start these drugs. So just as a reminder. So on the next slide, what I show you here is etrasimod, which is their phase 2 trial in UC. This was week 12 data. So this is earlier days. Now, obviously, we're going to look forward to the phase 3. The reason why we highlight the 2 milligram dose, that's the dose that they're going to take into phase 3. So it's less relevant what the light blue 1 milligram was, but it's the 2 milligram dose. And you could see it met its outcomes and gave rise to the phase 3 trial, which we will await both for Crohn's disease and ulcerative colitis. Etrasimod is both. Same as ozanimod, it's going to be, we're waiting for the Crohn's data, you know, to fully evolve so we can have an update on that as well. Next slide, please. So this is filgotinib, which is the JAK1 selective inhibitor as well. I'm showing you now the week 10 as well as the week 58. So this was the induction, and then at the end at week 58. Look again, biologic experience versus bio-naive. You can see a theme, right? The three of us are obsessed on this concept clearly because we keep highlighting the importance of understanding sequence. And I'm glad, Aline, that we had the night to sort of really explore this concept that I hope everyone will hear in their dreams is talking about sequence. So when you think about the bio-naive patient, you could see here at week 10, again, the most important impact was in the 200 milligram dose. So again, for filgot, it was all about the dose, not just whether they got TNF or not, but it's also that the 200 milligram dose met the outcomes of interest in both bio-naive, by the way, as well as bio-experienced. So I don't want to dismiss that, but it was only in the 200 milligram dose. Then when you combine everybody, same story, everyone who is either naive or experienced who went into maintenance are then evaluated, whatever your history of TNF was, and that's the week 58, showing you again the difference between the 200 and the 100, and clearly there's a major benefit of 200 as opposed to 100. So again, the dosing appears to be for 200 milligrams for ulcerative colitis. Next slide, please. Let's talk about the safety that's been up for discussion, as it is with all of our therapies, by the way. I'm sure after, and Aline, I could go on for an hour around the rheumatoid arthritis 1133 data that is making all of us nutty around ulcerative colitis. And like you said, unless you could see it in the population that matters, that we manage, it's hard with all this noise and all these press releases that don't even make sense. You can't even understand what non-inferiority press release even meant when it came to you discussing it the next day in clinic. So I think it's important to also understand that in the patient population that are that we are dealing with, do we see these adverse events? And as Dana showed, the long-term safety does not support the same degree that we see in the RA population. Here is, again, a story about a JAK, and looking at across the board, you can see the incidence rates or the exposures, adjusted exposure for serious herpes zoster. Just like TOFA, JAKs will always have a story around zoster. So good news is we've got our inactive vaccine, we've got Shingrix, we have a way of managing it. And you can see here a low incidence of opportunistic infections as well. But remember, even with long-term extension, we don't have decades of data. So we just need to keep communicating and keep learning from one another about what are the things we need to pay attention to and how do we counsel patients. Next slide, please. So again, the other sort of thing from DDW PTSD of 2019 was the whole change of the label for TOFA based on, again, a presumed thromboembolic events that were happening in 50-plus-year-olds on methotrexate, smokers, whatever the list goes on of risk factors in the RA patient population, that we had a serious focus on the idea that venothromboembolic events are a thing. Now, as Aline noted, having active IBD is a significant risk factor for venothromboembolic events. So what's more relevant, right? What's more important? And here it just shows you the very low rates, again, in ulcerative colitis patients, the patients that you're dealing with. You could just see the reality of the data. And I think together, again, we need to just follow up all of the real world data and make sure that we are appropriately communicating risk to our patients. And as Aline noted, using perhaps progesterone-based IUDs for patients, or Dana mentioned about thromboembolic events, maybe it has to do with hormonal birth control. There are ways we can prevent these events from happening. And number one is good disease control and preventable things like reduction of cardiac risk factors, smoking, birth control, et cetera. So we have that ability to prevent some of these risk factors. Next slide, please. So we all saw the various press releases from AbbVie as well around the excitement around upadacitinib, which is the JAK, also a JAK1. And they have like a huge program. So I'll go through the acronyms here. So UACHIEVE, which was the phase 2 sort of dose finding, and whatever the dose they were going to find from this study, they were going to seamlessly go into a phase 3, and 45 milligrams was the dose. So this was the sort of dose finding UACHIEVE component. And you could see here across the board, there were different dosing, and we looked at both endoscopic improvement at week 8, and that was really to inform us on what we were going to bring into the phase 3. On the next slide, you do see the actual 45 milligram week 8 induction UACHIEVE data showing you the huge deltas as you see like these large histograms. Now, one thing why this is exciting is it actually, so Dana, that sequencing slide, I'm dying to put up the UPA data for naives and see how that ranks, because we do see some of the largest deltas between placebo and drug that we've seen in a very long time with this drug. So this was, yay, a great advancement for our patients. And this was in a phase 3. This wasn't the phase 2. This was actual phase 3 data, which is always exciting. So this is just showing you again that histo-endo story, which again, you see 30% of our patients met that endpoint at week 8 of histo and endo improvement. So this is great. I'm like super excited about all these new therapies. We just have to learn how to use them. The next slide shows you the UACCOMPLISH, which is, as a reminder, in order to get for FDA approval, you need typically two independent induction trials. So they have you do sort of two parallel, just like what Dina presented, the OCTAVE program, which was for TOFA. They had two identical placebo-controlled induction week 8, and then they both fed into the maintenance. Same story here. So this is you accomplish the second after you achieve, cute, the idea that you have another 8 week, and it's showing you actually, if we compare them side by side, which is probably a better slide for everybody anyways, is just to show you how similar they were. Again, this had a 37% rate of histoendo improvement. So this is exciting, guys. This is like really sort of the next level of where we're going to present this data. But again, always keeping it in the context of safety. It's really important. So speaking of safety, thank you. That was your cue to the safety slides. So all we have, again, because we don't have the maintenance data. So as a reminder, these were presented in abstract form, press releases. Those are around only the induction data. And this is just showing you early days. I mean, at 8 weeks, can we really say anything? I just want to let you know, we will just say it looks like everything else we've used. So that's like the only thing you really could walk away with 8 weeks of data. So it's just important to know that there were no new signals, nothing new that we wouldn't be able to anticipate based on our exposure already to TOFA as being a JAK1/3. So more of a pan-JAK, and there's like 7 different cytokines that are involved in JAK1 and 3. So just as a reminder as to the difference. But again, nothing new, nothing different. And the same with you accomplished, which they also showed us the treatment emerging AEs at 8 weeks. So nothing different than what we're used to. So I think the great news is that we're getting data, more and more choices, and they look to be in keeping with what we know, right? So that's important as well, is that we're familiar now. There's a good thing about being first out of the gates when you're in a class, but there's also something to be second. So keep that in mind as to which one you may think we learn better from. So this is in the JAK1. The next slide just shows you where we are right now with mirikizumab, which is the first IL-23, which is a P19 only. So remember, as opposed to Ustekinumab, which is 12/23, this is 23 only. We call that P40 for 12/23, and this is P19 only. As a reminder, it is currently phase 3. There was a press release that said we met all our endpoints, but we're not going to show you a press release. So until we get data, we're just going to show you the phase 2 data. What we do want to explain is similarly that they found the dose in phase 2 that they took into phase 3. So just as a reminder, that's typically what phase 2 do. It gives us an idea, and we found the dose, and you could see here the different dosing regimens that they used, but the good news was it worked. How's that? In phase 2, it worked. Now we know that in phase 3, yay, there was I think it was just a picture showing check boxes next to every primary and every secondary endpoint for induction of remission in UC. That will be, as long as they meet in maintenance, that will be the first IL-23 we have for UC. Risankizumab will be the first for Crohn's, and then follow will be UC. And Guselkumab is the other one. And in Crohn's, most of them are going head-to-head against Ustekinumab. So this will be fun games over the next couple of years to see how our therapies play out. Next slide, please. And that was just showing you the clinical and then also endoscopic. Same story. We found it worked. We found a dose. We're moved to phase 3. And phase 3 mucosal data showed also a significant outcome. And I think that the end.
We're all coming back. Marla, this was so exciting.
Very exciting for this.
Well, listen, as you're saying, I'm so excited about the data on UPA and ozanimod. We're tweeting from MondayNightIBD saying how excited we were. So we were on the same page, because I think, you really pointed out that big delta that happens with ozanimod in bio-naive patients, especially exciting in terms of endoscopic improvement and histological remission. So my first question to you, and I'm sure you knew this coming, is how are you going to position ozanimod in your treatment? And really, like, in the ideal world, and then in the world where we're dealing with payers and having difficulty getting the newest therapy. Because like you pointed out, we often throw the latest therapy in patients who unfortunately have not responded or lost response to not only 1 or 2, 3, and 4. So then this doesn't make sense, right? And I think it's important to keep in mind for ulcerative colitis patient that maybe at some point we need to stop and say, okay, now it's time to see the colorectal surgeon, right? We're having all these therapies, but doesn't mean we need to go through all of them if our patient is getting sicker and sicker on current medical therapy. But just to bring back to the more optimistic point of view, and with the exciting data of ozanimod, how do you think you're going to use it? And maybe going back to our patient, would that be like a first choice for this patient? Yeah. And which patient would you use it on?
Yeah, so there's no, it didn't say, so this patient was not your patient, let's say, is naive to TNF. We saw that at week 2, there was already a significant difference. We saw an improvement in rectal bleeding score. We saw an improvement in stool frequency. We know that it works better before than after. Then I think you're right. This is an ideal patient. To be fair, that would be a patient that this could be an effective therapy. And I think it comes down to, do you have a bridge to, meaning is there a steroid event involved in this? Do you have time? It again comes back to time, because is this someone who we need something that we can't even wait 2 weeks? I'm not saying that happens a lot. Dana showed us the TOFA, inpatient data, et cetera. But I think if you have steroids as a bridge to anything, I think the world is open to a patient. That's the truth. If you have a refractory steroid patient, we think we need to act quickly, right? So that's where infliximab or maybe TOFA would come in if they've already seen, a TNF, maybe. But I think this patient, if you can use rectal therapy, which we don't talk enough about, by the way, but, rectal therapy as a bridge to, this could be a great patient for ozanimod. If you have a patient who's failed every biologic class, and then you're like, I'm going to throw an oral at it, I'll be honest, TOFA would be a better option at this moment, based on the data that we have. Again, it may evolve differently in real world. Real world is never the same as trials, so we know there's going to be a lot more data to learn from. But if that makes sense, I'd say you can choose your oral wisely. How's that?
It's going to be a new hashtag.
Use your oral wisely.
All right. Okay, well, Dana, going back to you, I also very excited about the UPA data, because again, like Marla was pointing out, it's really impressive, the delta in terms of clinical response, remission, endoscopic improvement. I think these are delta that are hard to see, are hard to come by. So what do you think about this? How do you think you're going to use it? When times come to use a JAK inhibitor, are we going to use TOFA, or are we going to use a JAK selective, something like UPA? How are you going to manage all these therapies now?
Yeah, I say it's getting harder and harder to do these talks because, it's relatively easy going back to, having, one class, then, 2, 3, so it's getting a little crowded here. And so I think there's a lot of nuance, and I think a shared decision-making approach is still going to be useful. Maybe it's too soon still. I have this delta shock from our Mondrian trials, right? The difference here being we're not looking at clinical remission based on a disease activity index, but we're actually looking at hard endpoints. And so I think that, it's very exciting. I said nothing has cracked the ceiling of infliximab, but maybe these things can start to get there. I also think, sequencing, we've all mentioned the theme of the day is how you sequence these agents. Well, if we're looking at long-term risk, where you said you need many hundreds of thousands of patient years, well, if I'm going to induce somebody with something that might have more risk, maybe the strategy will be that we're going to use these JAK inhibitors or TNF antagonists as induction therapies. And then you already showed those data that once you're a responder, maintenance at week 52, 58 is a lot easier, right? So could we actually develop a strategy to harness the rapidity and the strength of some of these agents, and then maintain with something that might have a better safety signal for someone? I will echo what you say, that our patient population is very different from rheumatoid arthritis, maybe more mobile, maybe younger on average, and so intrinsically different. But also our inflammatory bowel disease causes clots. Active inflammation causes clots. And I think that if we use these effective therapies early on, you're going to greatly minimize that. And if you look at the data from tofacitinib, you see the thrombotic events were in placebo groups early on. And so I think we have to really echo that, we want to, try to use these medications smartly. I'm very excited. I don't know if JAK1 plus JAK2 plus JAK3 is better than JAK1 plus JAK3, and I think that there's so many different combinations. Besides the ones we've mentioned, we have other molecules that are JAK1/TYK2 and JAK3 selective inhibitors. So I think the jury's still out. It's going to take a little time for it. It all shakes out in terms of safety and efficacy.
I think I would add just about the pregnancy story, because that will actually make a difference, because
Yes.
it just tweaked me when we're getting all excited. So I think that, as I was like, wait, there is possibly a scenario where we'd have to take pause. And one of them, as we've known for a while, the JAK inhibitors is something that, we don't have enough data. I don't want to say that it's completely impossible to have a woman get pregnant, and if it's the only drug that worked, and you have a good conversation with the patient and she's informed, it is a discussion between you and the patient. However, with ozanimod, because of its long half-life, its active metabolites have quite a long half-life, and it may take up to 3 months for full elimination. So I say to you that one where we would take pause potentially with the S1Ps would be in a woman of childbearing potential. Less so with JAKs, just because it has such a short half-life and it can be stopped. So I do want, and you don't have the repercussions of long half-life of active metabolites. So I just did want to remind everybody there will be a significant pregnancy warning. We do, however, we're presenting an ECHO. We have 60 pregnancies between relapsing multiple sclerosis, UC, and Crohn's, by the way. With UC, we have about 7.5 years of data of follow-up. There were 60 pregnancies. We had 2 congenital anomalies. One was a duplex kidney, one was a hydrocele. Both of them occurred in relapsing MS, not in our IBD patients, but we didn't have a lot of women under 40, interestingly, in the IBD trials. So that's interesting too. So there's a whole, again, digging deeper into understanding the patient population and understanding the data will require us to work together to uncover these real world data as things evolve.
Absolutely. And I think, I'm glad you pointed this out, because we have now such confidence in using the biologic in our young women of childbearing age and during pregnancy, that this is absolutely something to keep in mind as we're choosing therapy for our young women. But it seems that, like Dana, you were saying, there's so many therapies, but I think there's also many indication, not just in terms of disease severity and presentation and extraintestinal manifestation, but also age and life event and life planning. It seems like we have different options for different patients. But I think, as much as we are like, which JAK are we going to end up using? I think the most exciting part of what you both presented was that with every JAK, we have more reassurance in terms of the potential risk, right? The zoster we know, and it was very timely that the recombinant vaccine was available as those JAK inhibitors were coming out. But in terms of the DVT and PE, with every story, with every new JAK, we're seeing the same safety, that we're not seeing that increased signal. But again, I think it's important to keep in mind, the patient selection and minimize hypercoagulable state in our IBD patient and our UC patients. But I think, what I can get as, try to conclude this, because this has been an amazing discussion and I can spend the whole night with both of you, is that we have really exciting data. It seems that we, the fact that we're looking at now endpoints that are objective endpoint, endoscopic healing and mucosal healing, and we're seeing really exciting results with the small molecules and the JAKs and OZA. I think it's really giving kind of an edge or an extra hope in how we're going to manage our patient with UC. I think it's going to really shake up how we're going to position our therapy. What we presented today is going to have to change. But I think it's patient selection. That's the key message. It's patient selection and positioning. Which drug will continue to work if you use drug A, and which drug would not work that well if you use drug A, and which one is the best drug for, initial drug for our patient, presenting with UC. So I want to thank you both for this exciting evening, for all the good data you presented. It was really a tour de force, because it's everything you ever wanted to know about UC. And I really appreciate you spending the evening with us and sharing your knowledge and expertise and your enthusiasm for what's coming up in UC and all your words of wisdom. So thank you all for our audience for joining us, and for our partners, Integrity CE. Make sure you claim your CME credit, and see you at the next webinar.
Yeah, thank you so much for inviting me.
Absolutely. Thank you for being here.
Likewise. Thank you. Good night.
Thank you. Good night.